All right. Thank you again for joining us on the Lightning Step Couch. My name is Benjamin Turner. I am your behavioral health advocate. In this series, we put a spotlight on innovators in the behavioral health industry. And joining us today is Dr. Annie Peters. She is the Director of Research and Education at the National Association for Addiction Treatment Providers, also known as NAATP, located in the great state of Colorado. Thank you so much for joining us, Dr. Peters.
Yes, of course. Happy to be here.
Thank you again. Can you tell me a little bit about yourself, about NAATP, and your role within the organization?
Sure. So I am a clinical psychologist. I've been in the field of addiction treatment since about 2006. I've mostly worked in clinical settings, so mostly residential addiction treatment, specialty addiction treatment, also outpatient. I've done group, individual, lots of assessment, clinical assessment, psychological assessment, long-term treatment, short-term. And then a couple years ago, I learned about what NAATP was doing, particularly around measurement and moving the field forward with how we measure and improve addiction treatment. So I got excited about doing something at the national level. So I moved to this role and have been doing this since 2020. Yeah, so that's who I am. I'm also a person in long-term recovery, so I like to pull that in because I think that's important to balance the lived experience and the professional experience and talk about how we make this work better for people who use substances.
Absolutely. Well, thank you for that introduction and congratulations on your long-term recovery.
Thanks.
I know how difficult that can be, and it's great to see you stick in the organization or stick within the industry to help others through that process. I want to talk today, you touched on a little bit, but I want to talk a little bit about creating treatment plans based on psychological assessments and then measuring those behavioral health outcomes. So can you walk us through the key components of a comprehensive psychological assessment and what information is typically gathered about the patient?
Sure. So, of course, it depends what setting you're in. If you're in private practice and you're doing like the complete biopsychosocial assessment of the person's life and getting their full psychosocial history and things like that, if you're just really focusing on the mental health component and the psychological component, you would want to start with a screening to figure out kind of what are the big chunks that we're going to focus on. Is it depression, anxiety, psychosis, et cetera, et cetera. And of course, substance use, if you're the sole clinician, you want to assess for that too. So you're trying to get a diagnosis just for the purpose of figuring out what we focus on. And so a screening tool can help you narrow that down. So you can use something at the beginning, like a mental health screening form or a DSM-5 cross-cutting measure, something like that. And you say, okay, these are the areas I want to focus on. And then you really dive deep into how does this show up for this person? What does depression look like for this person? How is their substance use, if it's present? How does that impact it? Is it causing it, making it worse? Is it, how are those two related temporally in the person's life? So, and then besides just the symptoms and the diagnosis, you really want to, one of the main things is just rapport, is getting to know the person and why they're presenting for care. You want to make sure you touch on risk, or do they have suicidal thoughts? Are they, you want to touch on components of their life, like the social drivers of health, like their housing and their finances and things like that. You want to be, I would say part of it is trauma, looking at, childhood experiences, adult experiences, traumatic experiences that may be related to their substance use and or mental health issues. And you're doing a mental status exam too, just looking at the person, figuring out, how are they functioning cognitively, and just getting to know them and starting a relationship with them so that you can collaboratively work together to figure out what do they need right now and what are they going to need long term. So
awesome. Yeah, it's such a personal process, and building rapport with that person is paramount in creating the assessment, getting to know who they are, so that you can start to build a correct treatment plan. Correct?
Exactly. Yep.
Absolutely.
Yeah.
Can you talk a little bit about how the process may differ for various behavioral health conditions? Like, is somebody coming in for depression have a different assessment process than an anxiety disorder or bipolar or schizophrenia?
For sure. And it depends, what setting you're in. If you're in an inpatient or residential program where you can really focus on these things right away, and the person really has acute needs that you need to address quickly with medication. Or is this an outpatient setting where you're going to be treating this person for a while and they have a psychiatrist and you're going to be doing more of the relationship building and therapeutic work. But it definitely will differ according to the kind of behavioral health issue they have. And I mean, when you come to behavioral health and you're talking about substance use as a part of that, it's sort of what's the biggest threat to the person's well-being right now? Is it their active chemical use, their active eating disorder, their active suicidal thoughts? You want to see what's most acutely interfering with this person's ability to survive. And then you can get to the stuff that's interfering with what's preventing them from thriving. So, if it's depression, you want to, focus on reducing symptoms of depression, finding out what's driving it, determining if there's a need for medication. Again, that's similar across the different issues, but you're kind of triaging at the beginning, to figure out what do you really need to address first, what's medical and what's, what requires a medical intervention. And then, what are we going to work on therapeutically? Like, is it building motivation for change? Is it really focusing on symptom reduction? Is it more, so it just kind of depends on, and also on what the person wants to focus on, because they may be motivated to work on one thing and not so much the other. And so you have to kind of balance that out.
Yeah,
So
absolutely. And dual diagnosis is pretty common. We often see people that come in for addiction treatment with many underlying mental health issues, and it's important to address both to attack one or the other, correct?
yeah, ideally. And the challenge is that usually people are at different levels of motivation for different issues. So they may say, I'm ready to quit drinking, but I don't want to talk about my eating disorder, or I'm ready to work on my depression, but I don't want to talk about, how much weed I smoke. And,
Yeah, absolutely.
And so you kind of have to balance, helping them see what is really driving their distress, and also working with what they're willing to work on. So
absolutely. Yeah, it can be a difficult process to hammer out. So the assessment is complete. What are the steps for translating those findings into an individualized treatment plan? What is typically involved in that process?
Sure. So, if you're working in an environment where you have a care team and there's people who will be, like medical people who will be addressing anything related to acute withdrawal, anything related to current medical issues, great. And then you can focus, if I were a psychologist, I'd be mostly focused on kind of, from the ASAM perspective, the dimensions. I'd be focused more on dimension 3, which is the emotional, cognitive, behavioral component. If I'm also treating a substance use disorder, working on motivation and things like that. And also, depending on what setting you're in, looking at the person's home environment is really important. Is their home environment conducive to recovery? And if not, are there social needs that they have that we have to address really first before anything else? Like, do they not have safe housing? And then you're having to take more of a kind of social work approach to figuring out how to help the person. But it's a conversation with them. Here's what I'm seeing from the assessment. Is this an accurate assessment from what you're seeing? And let's make a plan for the different areas to work on. And so kind of coming up with a goal for each problem area you could think of. You also want to take kind of a strengths-based approach, focusing on what is this person's strengths. It may be that they have a great family, and how can they involve the family in their care and in the planning for their care. If they don't, then, how do we harness some of the other strengths they have? So yeah, again, kind of a collaborative process where you're hopefully working with other professionals that are treating the person, and also with the person themselves, and figuring out what to target.
Yeah. So with each individual being unique, each treatment plan becomes unique, correct?
Exactly,
Yeah.
for sure.
Okay. So we've done the assessment, we've put together a treatment plan. Now we want to measure the outcomes, correct? And what are some of the key indicators of progress or success that should be tracked as part of that treatment plan?
Sure. So I'd say there's kind of two areas. There's the symptoms. What are the symptoms of the issue we're treating? If it's, and what are our goals? If our goal is reducing their substance use, then obviously I want to be measuring how much they're using. If they have depression, I want to be using hopefully a standardized tool of some kind, a PHQ-9 or a Beck depression inventory or something like that, where I'm measuring quantitatively, so that I can really keep track of their progress. So there's the symptom-based measures, and then there's also that feedback process of helping the person here. Look at how your depression is decreasing, but your cravings for benzodiazepines is still really high. And so how do we address that? And then there's also just monitoring the therapeutic alliance. That's always good to measure, is how well are we getting along? How do you feel about your treatment? Do you feel like it's helping you? So there's symptoms, there's therapeutic alliance, and then also just anything in their quality of life, anything that's affecting their quality of life. So are their satisfaction with home environment, their self-esteem, their relationships, things like that. So making sure that we're keeping track of all those things, both quantitatively and qualitatively, so we know where we are.
Yeah, that makes sense. And so you as a clinical staff or the staff within the facility are taking those measurements and watching all of that. How can the patient themselves be involved in setting goals and defining what success looks like for them individually? Is there a role for shared decision making in developing that plan?
I hope so, yeah. We don't want to just be deciding the treatment for them, or saying, well, this is our program, this is the next step in the program. We want it to be based on the person. So that's where, the kind of feedback informed treatment or measurement based care comes in, that however you're measuring the person's progress, that you're reflecting that back to the person, asking them if that's how they see their progress, and there's still areas they need to work on, and then saying, well, where do we go from here? This is what I'm seeing. What are you seeing? And what do we need to work on next or more? So that's a key part of it, is we don't want to measure just for the sake of measurement. We want to measure for the sake of communication and progress and treatment planning. So
awesome. Great answer. I really appreciate that. So with that being said, what are some barriers that behavioral health providers face in effectively measuring outcomes? Time, resources, lack of standardized metrics. What are some of those barriers?
All of the above. With the workforce the way it is now, and the amount of increased substance use, depression, anxiety, and mental health issues, and just despair that we have in the world today, we've got our work cut out for us. And people who work in this field are really it's a job for heroes, I think. It's just that to be with a person in the times that are hardest in their lives and helping them move forward, it's tough because we almost always have fewer time and fewer resources than we need to be able to help the person. And so as a clinician, I know my first thing is I want to talk to this person, and sometimes I don't even want to, I don't want to give them a 10 question scale, and that takes away from the time I spend with them. But it's so helpful in tracking progress, and so I think one barrier is just a willingness of clinical staff to see that measurement is important. But we can't get everything in our brains really down into a good clinical note sometimes. So really keeping track of how a person is doing. But when it comes to behavioral health, we have many more good measures for mental health than we do for addiction. Obviously we can do drug testing, we can ask them about their substance use and their cravings, but we don't have one measure that everybody uses. And even depression, there's 4 or 5 that we see regularly used. So, so one is having the right tools, having the resources, the time. We're often just pressed for time. Technology is another piece. If people don't have the right technology to take good notes, record their measures, communicate with all the other caregivers in the team, if they don't have that at their fingertips, then that's a big barrier. So, yeah, we definitely have our work cut out for us. So it has to be
You
all
sure
of
do.
this in place. Yeah.
Yeah, absolutely. And we talk a lot about the patient themselves, and not enough time about the staff that's supporting them. What advice can you give to clinicians and staff within a facility to help alleviate the stress or help to cope with what's being asked of them? We see a lot of burnouts. We see a lot of
Yeah.
issues that come to the staff. Is there anything, you talked about technology, but is there any advice you can give to clinicians to help them battle any stressors that they're feeling?
Hmm. I think it starts with self-awareness. I used I used to do counselor education. We would talk about that the stress goes somewhere. It either goes to your coworkers,
Mm,
it goes back to the patient, which we don't want to think that happens. We, kind of patient blaming, or it goes to our leadership. We think,
mhm.
it's the leadership that's the problem, or it goes it goes home with us to our families, and sometimes it goes inside, and we get sick physically, emotionally. So I think starting with self-awareness, where is my stress going? And then figuring out what are the things that help me release it. Is it yoga? Is it
Mhm.
uh, community support meetings? Is it my religion? Is it good enough changing, getting a sleep assessment? Is it something medical going on with me? Making sure we know how to discharge some of that stress. I think every therapist should be in therapy themselves.
Yeah.
I think having good supervision is key, and having good so clinical supervision, but then also good therapy. That we have to have a place to dump our stuff, and those, and something bodily movement oriented, because the body keeps the score for our patients, and it does for the clinicians too. So, getting that stuff out of our body, out of our minds, and taking care of ourselves that way, you know, those are really key. We have to take care of ourselves, or we're not going to be able to take care
To
of other
take care of
people.
others. Yeah,
Yeah.
absolutely. Yeah, I'm a certified yoga teacher myself, so I know the value in physical movement for mental health, as well as self-awareness that yoga can provide, and taking an inward look. So
Yeah.
always a big advocate for yoga and physical activity for mental health. I do want to touch a little bit on technology. You had brought it up, and
Yes.
I just wanted to talk how there's technology being used in behavioral health that's outdated, that's not not geared towards behavioral health. We're using technology that may be used for primary care or other industries. How important have you found it to be to really have the right technology in a facility?
Super important. Although when I first heard of AI being used to write clinical notes, I thought, that's terrible. It'll
Yeah,
never
yeah,
capture, you
yeah,
know. But I think it's going to be huge to just help clinicians, keep track of risk and symptoms and all these things that, and then, uh, the human element we can add on top of that. That the uses of AI for things like documentation, screening, things that don't require a human cortex to, uh, will be huge savers of time and stress for clinicians as we move forward and get better with them, and having the right tools. I think wearables will be a big
yeah.
thing. Is not just asking people questions. I don't think we can ever get away from that because we want to know the person,
Mhm.
what they think of their lives, but being able to monitor their stress, their heart rate variability, their sleep, things like that. The more we can do that, the better, because it's we ask fewer questions, and so we have more time with the patient because we have all their data there.
Absolutely.
So,
Yeah.
and making sure it's all integrated, that the data here is talking to the data here, so that my doctor and my therapist and my case manager have all the information about me, so that the burden of integrating all that information is not on me, the patient. It's on the clinician and the
Absolutely.
clinical team.
Yeah.
So,
Yeah. And there really shouldn't be a burden on the clinical team to pull all that data together
true.
either. If the
Exactly. Right.
technology is where it should be,
Yeah.
we should be limiting how much effort is put on the staff to do that. And not only does it allow more time for the staff to be with the patient, it can allow more time for the staff to be with themselves, right? just
Exactly.
just
Yeah.
give them some more time with their family, or more time to take a yoga class, or go see their therapist. So the importance of technology is huge, and the better we can build that, the more we can do for the staff and the patient. So
Absolutely.
I have one last question to talk a little bit about outcomes. I know we got on a little tangent there, but I want to bring it back. So when we talk about aggregate or outcomes data,
Yeah.
how can we aggregate that to be leveraged on a larger scale to evaluate the effectiveness of different behavioral health interventions, and so
Right.
that we have a more worldly look on that?
Good question. And that's really what I do now, and that's what I do at NAATP. So NAATP created a foundation for recovery science and education, which is abbreviated FORCE with an S.
Mhm.
And that's my main job now, is exactly how do we do that? How do we take the data that we're collecting from clinicians, from technology, pull that together, and then use that not just to help each individual patient, but to help providers too track how are our patients doing overall? How are our patients of different racial groups doing relative to each other? Are there just racial disparities? Are there disparities in how we treat people with different gender identities? And then, how do different interventions, what are the outcomes of different interventions? And part of that is research, but the real research takes a really long time. And now with technology, we can kind of move faster than that. We still want to be doing really rigorous, well-controlled research studies on interventions, but we also want to be sharing information as much as we can that's outside of a research lab kind of setting. And so that's what FORCE does, is we pull together fully de-identified outcome data from different treatment providers, and then give information back to providers saying, this is how much your patient's craving is decreasing while they're in treatment with you, compared to 99 other treatment centers across the country. We have 100 treatment centers now in our program, our outcomes program. And so, being part of something like that, whether it's through Force or with your EMR or with a researcher or, a state information exchange, getting that information as a provider to see not just how am I doing with each person, but how am I doing overall. This will be more and more important with reimbursement and showing our value. And really with addiction treatment, particularly, we're behind the times because we're still sort of seen as not quite real healthcare to an extent. And so to get into to be a part of the conversation around a person's health and healthcare, we have to be, sharing as much as we can about outcomes and data and using data for the right reasons. So making sure that we're part of initiatives that get big picture looks at data and pull insights out of data is going to be so key to demonstrating that we are effective at what we do, that we're helping people transform their lives. We can't just do that in a bubble, so we have to collaborate and work together to make that happen.
Absolutely. The Force program is really exciting. I love what you guys are doing there, and it's really going to benefit everybody in the long run. The more data we can get, the more we can collaborate, the better the outcomes will be, the better the patient care will be. And I believe we're going to be visiting you guys at the NAATP conference later this year, so I'm excited to meet you in person if you'll be there.
I will be there.
I really want to thank you for your time, Dr. Peters. This has been an incredibly informative conversation, and I really thank you for joining us.
Absolutely. Well, thank you for having me.
Yeah. Is there any last words, anything I didn't cover that you really want to touch base on?
Nothing comes to mind. Just
okay. Yeah.
If you're working in this field, keep on and be kind to yourself.
Absolutely. You hear that? Be kind to yourself, everybody. So again, I want to thank you for joining us. This has been another amazing talk on the Lightning Step Couch, talking with behavioral health innovators. More to come. Thank you so much, Dr. Peters. I really appreciate your time.